Thank you. Thank you for having me. Today, we're going to talk about homelessness in general. We're going to talk about the state of homeless healthcare in New York City. And then, of course, we're going to talk about my area a little bit, which is specifically serving people who are street homeless, right? Because when we talk about homeless people, we're talking about everybody who's in a shelter, couch surfing, anybody who's doesn't really have like a permanent placement. But like I said, my area is specifically serving people who are street homeless, or rough sleepers is another way you might hear it. I'm going to start with an anecdote about engaging somebody. One of the things that we talk about when engaging people struggling with homelessness is a lot of people have both internal and external barriers to engaging in healthcare. And we have to be pretty creative, and we have to take our time. A cornerstone of the care that we provide is really sort of old-fashioned, slow medicine. A lot of times I feel like, I've got my backpack full of antibiotics, but a little bit I feel like a country doctor with a bag, slowly going from person to person and taking as long as it takes. So on this occasion, I had a case manager who was really concerned about this guy who, the case manager was just really worried about his health and took me to see him. And the guy was like, no, I don't want to meet her. I'm standing, 20, 30 feet away. And he's like, no, I don't need anything. I don't want to meet her. And he says, well, can she at least meet Maria? And he's like, yes, she could meet Maria. So this guy had a pet chicken in the doorway where he was living on the Upper East Side. And that was sort of my in. The very first day, I only got to meet Maria. I did not get to so much as like take a blood pressure. But what that was starting the relationship. And that is a big barrier to a lot of the people that we serve is they've either had trauma through healthcare or they've internalized, our cultural stigmas about substance use disorder, mental health disorders. And so there's just sort of this barrier to entry to getting care. So that was the first, just establishing the relationship and that I was just like a friendly face. But let's talk about homelessness overall for a minute. So let's go zoom out a minute and like set the stage, right? Homelessness, as I think everybody probably knows, is a huge national problem. New York City, though we have a really high homeless population, we actually have lower per capita than a lot of other cities. And the reason for that, I don't know how common knowledge this is because we're the only state that has a right to shelter. There are a few other states that have right to shelter for like families, I think Massachusetts, but New York is the only state that has a legal right to shelter for homeless single adults and everyone. So we have a lower per capita rate because of this legislation or because of the lawsuit in the early 80s. And then the creation of our Department of Homeless Services in 1993. So who's homeless in New York or how many people are homeless in New York? It's about, about 20,000 singles, about 20,000 children, about 20,000 adults are all in shelters. Shelters and safe havens, but predominantly shelters. Real quick, does anybody here, how much experience do people have working with people in homelessness? Does everybody know like what a safe haven is? Yeah? Okay. So shelters and safe havens, and then about 3,500 people at our last Hope Count. The Hope Count, is the annual where we're just like, how many people are sleeping on the street? They do it in the winter, so that's the winter number, right? The summer number is much higher. It's actually coming up next week. If anybody is just interested in doing it, you can volunteer and you walk around and you say, hey, are you homeless? And you click yes, one. And every single street is walked just looking for people who are sleeping outside. So that's where we're starting as far as where our numbers are in New York. Unsurprisingly, it's disproportionate number of Black people who are homeless compared to the general population. That's something that we're paying attention to, especially in our own population of healthcare providers. Ideally, we would reflect the same population as that we're serving. We're not. We're working on it. That's an important thing to pay attention to. These are the Hope Count numbers over the years. Relatively steady. I think it's interesting to look at it in comparison to the outdoor temperature. because the temperature does make such a big impact in how many people are outside. Like I said, the summer, the numbers are much higher. I don't know if that's why it's counted in the winter, or if that's, you're not truly street homeless unless you have nowhere to go when it's 20 degrees outside. But that's an interesting thing to look at. Then we've got so these kind of contrast. You've got the numbers of people who are, rough sleeping outside over the years, hovering around 3,000 for about the last 10 years. And then you've got the shelter census over the same period of time, which was much lower in 2010, closer to 30,000, and is now closer up around 60,000. I'm not really sure why this slide is blank. It had words on it. Well, if the slide wasn't blank, what it would say is about why people are homeless, right? Why are there 60,000 people in the shelter? Why has that gone up? Why are there people sleeping outside? And it's about a third, a third, a third. So a third of people who are coming out of institutions, either long-term hospitalizations or incarcerations. A third of people who are incarceration, a third of people who are just struggling with substance use and mental health disorders. And what's the other third? I wonder if it'll load if oh, there we go. Right, just the economy, right? So people who were barely able to maintain their housing are shifted into homelessness due to inflation, not enough housing, rising housing costs. So most of the people that Janian works with, we work with people, I would say, in all of these areas. Street medicine, I would say, is specific to that top third, right? Is almost exclusively people who have substance use disorders, severe persistent mental health issues, or oftentimes both. So the history of Janian, we started as a psychiatric organization. It was all volunteers in the 80s. The psychiatrist, Catherine, was looking around on her way to and from work, noticed there were a lot of homeless people who seemed to be having mental health issues. So she started getting other volunteers, changed it into a nonprofit. And then in, let's see, in the early 2000s, Janian, it was changed from PPOH to Janian. So PPOH, Project for Psychiatric Outreach to Homeless People. They changed their name to Janian and joined CUCS. They changed their name because at that point, that's when we started our primary care services, it was in 2012, and then joined with CUCS, which is a larger social services organization. And then a few years after that, we decided to start doing street medicine. So that was 2016. We serve people in pretty much all of the boroughs. So predominantly Manhattan, Brooklyn, and Queens. And I would say the Bronx, we don't really have very many programs in Staten Island. But we serve people through all the stages of homelessness. So from street homelessness in temporary and also in permanent supportive housing. Now, obviously, not everybody goes to permanent supportive housing. Some people may be in independent supportive housing, but there are permanent supportive housing sites that have on-site primary and psychiatric services. Okay. So now we're back to street medicine specifically and what we're doing. And our goal, again, is, like I said, it's sort of a slow medicine, a little bit old-fashioned, if you want to think of it. And we're trying to provide not just good enough care, but I try to provide the care that I would want for myself or for a loved one. Really, it's a little bit like boutique medicine, but out on the street, which can be a little tricky at times, given that people often reject, first, second, third line evidence-based practices, but we do our best. So I'll get there. So how do we provide really high quality services? One of the key reasons why we're able to really effectively reach people and figure out who we're supposed to see is that we're integrated into the outreach teams. We're integrated into outreach teams for Manhattan, Brooklyn, and Queens. There are also outreach teams for Bronx and Staten Island, but we just don't have to work with them. So the outreach teams canvass 24/7. They have a designated catchment area depending on the team, and they canvass 24/7. They find out who's homeless. They connect them to services. They offer them housing services. They offer them connection to Medicaid, Social Security, food stamps, whatever it is they're interested. And they also assess them for any medical or psychiatric needs. And then if they find they have medical or psychiatric needs, then they refer them to us. And I think why this is a particularly effective model, when I've talked with different teams who have street medicine across the country, one of their top priority is always going to be housing. So if you show up and you say, hey, do you want me to look at your feet or your hypertension or your diabetes? People are interested in that, but primarily they want housing. So if you don't come with somebody who is also offering housing, it's hard to really get anywhere because understandably, it's just not the top priority. So we're integrated with the outreach teams, and like I said, in Manhattan, Brooklyn, and Queens. They give us that initial referral. They come with us, when they have a relationship with somebody to say, hey, these people are legit. And then they help us keep track of people, right? So they're telling us, oh, this person was incarcerated, or oh, they're in the hospital. Oh, we did get them this housing opportunity. And then we follow them until they're able to meaningfully engage elsewhere, right? So we're seeing them on the street. Maybe they move into a shelter or a safe haven. If that safe haven has on-site services, a lot of times it's one of my JDN colleagues, and I can, do a warm handoff to them. If they don't have services, then we continue to see them in that shelter, like I said, until they're meaningfully ready to engage in the community. And a lot of times that doesn't happen until somebody is in permanent housing. So for the street medicine program, we do see people across many different, anywhere from the park to their shelter until they're really ready to take on that care themselves. Or if we feel like, they're not really going to be appropriate for a permanent independent living situation, we're going to advocate with the team to place them in a permanent supportive housing site where it is an independent apartment, but there's a primary care provider, on the ground floor that you can see. And so we'll advocate for that if we feel like it's somebody who may struggle to maintain their health care in the community. These are just a little bit of the stats for the Manhattan outreach team that we work with. They're pretty effective as far as getting people into housing. We do work on a housing first model as far as there are no other barriers that you have to overcome in order to get housing. I mean, that's true as far as you can get placement in, a stabilization bed, a safe haven, a shelter without any barriers. You do have to engage in getting whatever benefits you're entitled to as far as Social Security or food stamps, sort of get your benefits in order before you're eligible for most permanent housing opportunities. So the barriers that a lot of our patients face, again, that goes back to what we were talking about earlier, as far as the two categories I like to look at are internal barriers and external barriers. There's some overlap there, right? These are mostly, the external barriers where their Medicaid might be restricted. They might not be eligible for Medicaid. They might be undocumented. And then you've got, your internal barriers, which are a trauma history, co-occurring substance use disorder, things like that. So we do everything that we can to remove the external barriers, by bringing the healthcare to them. We do full service primary care on the street through a combination of carrying backpacks around, or sometimes we bring out a medical van that's like a small mobile unit. And then the other part of it is just building trust. I don't know if anybody else has read, there've been more studies that have come out, especially since the pandemic, about who's accepting vaccines and who isn't. And what I've seen consistently, it's the people who have an ongoing relationship with a provider who tend to accept vaccines. And that has been our experience also through the pandemic, is the patients that have known me for a long time will accept vaccines. And when you walk around and just say who wants a vaccine, we get very few takers. So we're integrated with the outreach team. We really do a person-centered approach. We take as much time as needed to build trust and really put, the patient's agenda as far as their healthcare first. And we do a little bit of harm reduction. We're not like a needle exchange program, but we do provide people who are patients, we provide them with safer injection supplies, as needed, or connect them. There kind of depends on the borough, right? So Brooklyn and Queens, it's a little bit not as quite full coverage as far as other harm reduction organizations, whereas like Manhattan has a lot of places where they will actually like deliver harm reduction supplies to somebody's street location if they're not able to come in and pick them up themselves. They'll have roving teams that give out supplies. So we don't have to do that as much, but we do as needed. Excuse me. So, so this is a patient that I was working with several years ago. He was very free with pictures and giving interviews and comfortable. So I have his permission to share a little bit of his story. He had diabetes, and he had hardware put in his leg several years earlier. And when I met him, he's on the street, pretty entrenched in his street spot. You can't quite see it here, but there's a tiny hole here, and it's right over where the screw was, his leg, and he was one of the back too. Just a little virulent circle right over that part there. And I really wanted him to go and get that hardware taken out, and it does its job, and it's illegal. And he was terrified to go to the hospital. And I think it took more than 6 months. And I was, he was, like a lot of people, he, was worried that they were going to cut his leg off, right? He had a parent with diabetes, and like many people was like, well, once you start taking insulin, then that causes you to get amputations. That's a lot of people that I see have that connection between insulin and amputations. Once you start taking insulin, then they start cutting your toes off. And it's really hard to combat that or to like provide other information. So, but repetition is what I found worked. Building the relationship. We brought him Trulicity on the street once a week, even though he probably, insulin would have been better. That just like wasn't manageable. We had an amazing reduction in his A1C with Trulicity alone. I think we had like a 4-point reduction in his A1C with only using Trulicity. I'm a big fan of the once a week diabetes meds, even though it's not like first line to use them independently. So many of our patients will lose pills get stolen. We can come visit them once a week, and I've seen just fantastic reductions. So over the course of about 6 months, he finally admitted to me how scared he was of having his foot removed. I think I went personally with him to the ED to get this investigated. He told me even more about what he was scared about. I talked through, he thought once you, consented to surgery, you had to consent to the carte blanche, they do whatever they want. So I talked to him about, about if he could consent to them to remove the hardware, but he didn't necessarily need to consent that they could cut off his foot. And, I think after our second or third trip to the ED, he finally got the hardware out. But again, that wouldn't have been possible without our outreach team too, because he's also worried about all the stuff being stolen, right? He had quite a few belongings on the street. So they got him a storage shed, a storage facility, got that paid for. Then he finally went to the ED and got this hardware out. Started walking. His A1C got even better because he had weight gain from being sedentary because he couldn't put weight on his leg. It was amazing, but it was, it takes a lot of resources, a lot of time. And as far as like relationship building. Okay. So I'm gonna just wrap it up here. This is our mobile medical van. We have 2 of them. Like I said, sometimes you go out in the van, we've got 4 4 full-time teams and 2 vans. So you're not always with the van. So, we kind of rotate them so people can use them. It's a little bit easier to do phlebotomy, EKGs, things like that. It's just like you can see you've got a little phlebotomy chair. And so it's a little bit easier to do some of those if you want to get like an ABI. We've got a Doppler. But that's one of the things that we use to engage people. These are some of the common health conditions that we see. Those are self-reported. These are from our data, what we see. And this is not, I would say HIV is actually pretty far down on the list. The first 4 are really our heavy hitters. Trench foot, frostbite, body lice, malnutrition. These are all things that we see quite a bit of. And like I said, a lot of the care that we provide, it's really working with people, really like working with their delusions in some case. We had a gentleman who had frostbite. His great toe was completely necrotic, but he felt very strongly that it was going to come back. Our nurse went and visited him every week, sometimes twice a week for several months, just to monitor for infection and try to advise him. He never wanted to take any prophylactic antibiotics, but what she did was she really learned about his philosophy of healthcare. And his philosophy was sort of like an earth, wind, water, sort of really homeopathic. And so what he wanted to do was soak his necrotic toe in water for 4 to 6 hours every day. So of course, we were really worried, tissue is really macerated, we're concerned about infection. But instead of fighting that sort of, she wasn't going to convince him that wasn't true. So what she did was she went with his thinking on that and started talking about the balance between air and water and not wanting to go too heavy on water and maybe do a little bit more air. So only soak it for 20 minutes and then maybe it actually needs some sunshine. So she got him to pull way back on the amount of hours that he's soaking this necrotic toe and go more heavy on like air and sun and then monitor it. And it successfully auto-amputated without infection. So big win there. And I think we're just about out of time. So back to Maria. Another, like I said, slow engagement. This gentleman, his main issue that he was struggling with was very, very heavy substance use. He was afraid of judgmentalists, people who use substances have all of the same cultural indoctrination that we all do about substance use as a moral failing. He was severely afraid of judgment. We started with the chicken. Over the month, we got to a Suboxone induction. He's stable, reconnected with his family. Really wonderful. So I hope I did a good job in the 30 minutes, kind of a soup to nuts of homelessness to exactly what we're doing for street medicine. Does anybody have any questions?